Now it's time to introduce the one that does not need an introduction, I believe. Dr. Suzanne Al-Attar, you all know her. She is anyway a professor of medicine and rheumatology at King Abdulaziz University, Jeddah, Saudi Arabia. Dr. Suzanne, the floor is yours.
بسم الله والصلاة والسلام على رسول الله سيدنا محمد أشرف الأنبياء والمرسلين. Welcome to the 10th Saudi Society of Rheumatology meeting. I am honored today to present what I consider as one of the important studies in the field, which is entitled as the real-world effectiveness of the upadacitinib in patients with moderate to severe rheumatoid arthritis. I'll be presenting the 6-month data from the observation UPHOLD study. So first of all, these are the disclosure of myself as well as the authors, and I would like to welcome Dr. Rajai, who's joining us today, and he's one of the authors within the Middle East. These are the disclaimers. Now, the study itself, it have been presented before in the form of the methods in the UPLAR meeting, but the 6-month data have been presented with the real-world effectiveness within the recent ACR 2030. Now, the introduction. The efficacy and the safety of the upadacitinib have been demonstrated previously within the SELECT program trials. Now, we always know whenever we talk about any trials, we have the RCT trial that represent a homogeneous group of the population that give us the efficacy of the drug. But then we would like to have the real-world data in order to give us more heterogeneous group of population. The patient that we see on a daily basis, the patient that we see with other comorbid illness. So the UPHOLD study, it's for the safety and the efficacy of the disease in moderate and severe RA patients. It was a multinational observation, real life, real patient in 19 countries across the globe. So looking at the objectives and for the methods, the patients were included from 2020 until 2023. Now remember, in 2020, it was what? The COVID pandemic. So if you would like to look at the primary endpoint, that is looking at the DAS remission less than 2.6 within 6 months, as well as the sustained remission. Now, whenever we have any demographic, there are certain points I would like to know. First of all, the RA patient. We know that female, they're commoner, and indeed, that's what the real life show. But look at the disease duration. Disease duration is almost 10 years, which means that the patient had the disease for a longer period of time. Look at the DAS. The DAS, mean DAS is about 4.6. That represents the moderate to severe disease. And actually, the patient, they were on, they had more than one comorbid illnesses. In addition, about 50% of the patient, they were on monotherapy. So what's the method that we used? We care about statistic analysis. First of all, there is the FAST. What's the FAST? It's the full analysis set, which means patients have been receiving more than one dose. Now, the other two important with statistical analysis, and I would like you to pay attention to that, it's something called as observed and the non-responding mutation. Now, the non-responding mutation, it's used a lot in the RCT trial. It represents a stringent type of calculation in which the patient who doesn't or drop out, they are considered to be non-responders. Now, on the other hand, we have the as observed, which is less stringent, mainly used in the observational trials in order to include more patients. Now, 13% of the patients, they were prematurely discontinued at the study before 6 months, in which 4% of them lack of efficacy, and 4% they stated that they had a side effect. Now, let me give you a glance about one of my patients who dropped out of the study because of the side effect. She developed herpes zoster. And you know what? She didn't know that it was herpes zoster. She presented to the clinic and stated, I have a minor rash on my chest. Could you please look at it? And this is the classical teaching with regard to the JAK inhibitor. So it was non-harmful, it was painless, and I diagnosed her as herpes zoster. Later on, she came to me in the clinic and she was crying. She was desperate. Why? Because her husband is suffering from chronic renal disease on dialysis, and she have grandkids. During the duration, the 10 days, when the disease was cresting, she couldn't hold them and hug them. So she was crying to stop the medication, and we considered that as a side effect. Now let's look at the key results. What we care about from the trial is the DAS remission, less than 2.6. And if you look at the DAS remission with the MRN, that is the non-respond imputation, that is the stringent type of the statistical analysis, actually, in case 44% of the patient, they achieved the DAS, and with low disease activity, 56. The second question, if this is compatible to the RCT SELECT program trial, and I will tell you yes, because the remission in the RCT was about 44%, and the low disease activity was about 50%. Now moving on to the traffic light system. What we care from the trials is the percentage of remission. What I care in the clinic, I want to know, did my patient the percentage of achieving remission or low disease activity? So if you look in this traffic light bars, there is the yellow and the red. The yellow and the red represent the high disease activity as well as the low disease activity. So if you notice at the baseline, the SDI and the CDI for both situation by the CDI and the SDI, it was 90%, almost more than even 90%. This is huge, but this is real life experience. So at the baseline, more than 90% of the patient, indeed, they did have more than 90% of high disease activity and moderate. And what do you see? After the treatment, they went to low disease activity as well as remission in more than 60% of the cases. Fantastic. So we know right now that the drug is effective. We know that the drug, we will achieve remission as well as low disease activity. And you know what? If you remember, in the systematic literature review and meta-analysis that was published in 2019, again, that was before the era of the JAK inhibitor being extended all over. It was mainly the biological DMARD, the TNF, and some of the other mechanisms of action. But the target synthetic DMARD wasn't widely available. At that time, the maximum number of achieving DAS remission within 6 months' time was only 15%. So when I present to you that is a drug achieving remission more than 60%, this is what I want to have in my patient. So indeed, we know it's effective. Indeed, we know that the patient will achieve remission, but I want to know about the safety. I don't want to kill my patient. I don't want my patient to have any side effect. So if you look for the death, it's 0.3%. But what did I say earlier? That the enrollment of the study was during 2020. That's the time of the COVID pandemic. Patients were dying with comorbid illness because of the COVID. They were having as well as interstitial lung disease and obesity and on steroids for many reasons. Now, the other side effect that Dr. Osama Al-Hijri, he talked about is the herpes zoster infection. Look at the number. It's about 2.6. And I always say in my teaching that the magic number is what? The magic number is 3. So it is comparable. And the vaccine, what's the percentage of the incidence of herpes zoster that is going to be decreased of the vaccine? Almost 40%. So I am keen to know if we did a systematic literature review meta-analysis, let's say in 5 years from now, after the emerge and the widespread of the vaccine, how would our patient behave? Now, what about the MACE? We're concerned about the MACE. Dr. Rajai, he presented many abstracts in the last EULAR and the ACR. There were lots of systematic literature review as well as the real-world experience, almost 8 abstracts. They were talking about the real-world experience, and the MACE incidence was almost 0 to 1. And this was compatible with the similar finding. Now, as I stated earlier, I told you about the risk factors, but I'm going to talk about in the detail right now. More than 50% of the patient, they had more than one cardiovascular risk factor. About 20%, they were actively smoking. 20%, they were ex-smoker. But look again about the VTE, the MACE, and the PE. Again, the MACE is 0, and there's a small number of VTE patients. So in summary, the 6-month data, first of all, upadacitinib, it's effective in patients with moderate to severe rheumatoid arthritis. We are able to achieve the DAS remission almost in 40% of the patient, as well as low disease activity. The benefit-risk profile, it's very minute, but you know what? It's in our hand to decide which patient will benefit from it. And if you would like to know more about the one-year result, I guess you have to visit us within the next EULAR, inshallah, when the abstract is presented. And then I will tell you the exact detail and the post-hoc analysis that you have questioned for. Thank you so much, and I'll open the floor for discussion.
Thank you very much, Dr. Suzanne.